Hip Assessment Part 2. This is the objective tests continued. So following on from our observation of the hip area and the lower limbs in general, we're now going to move on to our active range of movement, passive range of movement, muscle testing, special testing and palpation. Active range of movement. Whenever considering any joint, we must also look at the available ranges within that area. And within the hip, we have flexion, extension, abduction, adduction, and medial and lateral rotation. When we're looking at active range of movement, we should always compare the left with the right and potentially, or preferably, measure and look at the pathological side last. So test the patient's normal side first to know their normal feel, and then look at the pathological side. Always try to use a goniometer to measure the range and put your answers in a table so that these can be referred to later on. It's useful to consider what position the client needs to be in for testing. Do they need to be weight bearing? What is the effect of gravity? What bearing will this have on their active range? As you move through the active range, always consider, does the client feel their pain, stiffness? Is it at the start of the range, the middle, or the end? And particularly something that most people may get confused over is it their pain? Keep asking, is that their pain or just a normal ache that may be associated with a different pathology? Always look and ask for if there's any associated muscle spasm, and particularly with the hip joint, what is the quality of movement like? Sometimes people will introduce cheating or substitution movements, which may involve the lumbar spine and pelvic area, and these are worth watching out for, and they will be considered in more detail in the practical element of the course. You may need to modify your examination of the active range of movement in order to bring on their pain, and this might involve changing the speed of the movement or doing a number of repetitions. Next, it is useful to work onto the passive range of movement. Passive range of movement involves holding the area and moving the hip joint through its normal ranges. And these physiological ranges of movement, flexion, extension, abduction, adduction, medial and lateral rotation, will be assessed on both sides in order to feel the end feel of the normal and compare with the pathological side. It's always useful to know what the normal ranges of passive movement are, not only for that patient, but within a normal population. Note down your range, where pain comes on, if there's any spasm, and what is the end feel of the joint like. End feel will be considered in the practical element of the course. What is the difference between active and passive movement? Is there any difference in range? And why would this be? Is the movement truly passive? Sometimes patients will like to join in with the movement, so I'll ask them repeatedly to relax as much as possible. You may choose to do some accessory movements of the hip at this stage, but this will depend on your clinical assessment and what you have assessed and found subjectively. Next, it is useful to move on to the resisted muscle testing. What muscle groups will need to be tested? What is the best position? And consider the effect of gravity. Also, you may consider combining joint positions, such as working rotation and flexion together, if this is something that has come out during the subjective assessment. At what point in the range should resistance be applied? And the normal standard is to apply resistance isometrically in the midpoint of the range. But this may need to be varied in order to elicit or bring on the patient's pain. Sometimes further equipment might be needed in order to further elucidate where the pain or potential problem is coming from. such as using an isokinetic machine. Always consider whether there is pain, spasm, weakness on testing. After testing the strength of the muscle, it would then be useful to go on and test the length of various muscles. Within the hip joint, there are some special tests around the hip joint for testing muscle length. For example, with the hip flexors, the Thomas test is useful, and we will go through these special tests for the length testing in the practical component. But just to run through them now, Thomas test for the hip flexors, the hip adductors, the hip extensors, particularly the hamstrings, looking at the 1990 test, the hip abductors, particularly TFL, which is Ober's test, and the hip rotators, especially looking at the lateral rotators or piriformis. Finally, we can move on to the special tests for the area of the hip joint. We can look at Craig's test, which, as mentioned before, is an assessment of the retroversion and anteversion at the hip joint. We can look at Faber's test, which stands for flexion, abduction, external rotation, and is a useful way of excluding general hip pathology. In 4-point kneeling, it can be useful to look at the relative movement of the hip to the lumbar spine. The acetabulum or scouring test is a useful way of testing for hip impingement or labral problems. If there has been a leg length discrepancy picked up in standing, then at this point it's useful to measure the apparent versus the true leg length measurement. It may be applicable to test the vascular system by looking at the pulses, and it's also useful to know the capsular pattern of the hip. Should this be tight, is flexion, abduction, medial rotation. Proprioception is a useful way of assessing the balance and feedback supplied from the hip joint itself. Always look at the integrity of the nervous system if this has been indicated, with dermatomes, myotomes, reflexes, and neural mobility. It is then finally appropriate to palpate the area. You may see signs of swelling, although the hip joint is relatively deep. There may be signs of heat or muscle spasm. So palpate the area of pain and appropriate associated areas.